Thank you, Dr. Asim, and thank you, Dr. Tarachan, for this invite, and thank you, Tarun and Horizon team, for providing the logistics. So we had some interesting discussions just before, and the last talk was by Dr. Akhil, and there has been much discussion about metastatic urothelial cancer. Let's put that into the clinical perspective by going for an actual case. Uh, so let me just remember the names. Tarachan, Dr. Lalit, Dr. Ankur, Dr. Devesh, and Dr. Jitendra. Please tell me if I will be missing someone in the discussion. So to start with, now urothelial cancers, the bladder cancer is the most common urothelial cancers, and day in and day out, we see about 90% of them are in the lower urinary tract. Only about 10% are there in the upper urothelial tract. So most of the discussion will revolve around a urothelial cancer. And as I can see, including me, all the colleagues are panelists are medical oncologists. So we'll not discuss anything related to surgical or the radiation management of a locally advanced or regionally metastatic bladder cancer. It will be full-fledged metastatic cancer, not amenable to surgery or any local therapy. So here is a 62 years female who has hypertension, which is well controlled on oral drugs, and hypothyroidism, which is again well controlled on oral drugs, who presented with a single episode of hematuria. Cystoscopy revealed a 4 into 2 centimeter growth near left vesicular junction, which was partially obstructing the VGJ. Biopsy of the same growth revealed a muscle invasive bladder cancer, typical urothelial cancer. So there is no confusion, a clear-cut case of a muscle invasive bladder cancer. On doing the staging workup, the tumor was found to be there in the bladder, the regional lymph nodes, the para-aortic lymph nodes, and there was one lesion in the right adrenal as well. So a typically metastatic unresectable urothelial carcinoma. So without going into any controversy of resection now or future, we will label this as unresectable. And in the workup, further workup, blood profile was normal. The only thing noticeable was a serum creatinine, which was 1.1 with the upper limit of normal of 1. So we start with Dr. Lalit. So, sir, how will you proceed to manage this patient? Now we have a metastatic, non-resectable urothelial cancer, performance status 1, with only one finding that the serum creatinine is slightly on the higher side, 1.1. So how will you manage this patient?
So before starting or discussing the first line options with this patient, I would like to assess this patient for her Pdl1 status. So that is the first thing I would like to know regarding this patient.
Pdl1 status. What do you want to specifically find out about Pdl1 status and why?
The idea is to whether add on immunotherapy, immuno-oncology drugs along with the first-line chemotherapeutic agent, and to give the patient idea of what magnitude of advantage she might be able to get out of it.
Okay, but sir, we have still not decided the backbone of the treatment. If you can understand my dilemma, creatinine is on the higher side. Unless until
So
patient is a
with
poor
the 60,
performance.
okay, got your point, sir.
Yeah.
With a 62-year-old female with a good performance score and just a borderline creatinine, not diabetic, though she's hypertensive, I would be comfortable putting her on a cisplatin backbone, sir.
Okay. So let's hear from Dr. Devesh. Dr. Devesh, now we have a lady who doesn't have any comorbidities, only slightly raised serum creatinine. And if you would have noticed the cystoscopy finding, there was left VGG obstruction. So in this patient, as Dr. Lalit sir said, that he would be interested in knowing the PDL1 status on the biopsy. So what will be your take on managing this patient further?
First, I will do palliative resections of this tumor with the help of urologist, so that sometimes the growth is near VUJ and maybe creatinine is normalized after this tertiary resections, and then we'll decide further chemotherapy backbone arm. So just in this patient, I think she is fit, 62, female. Actually, I will put on upfrontly with chemotherapy followed by the avelumab maintenance. So first I will do this that the palliative resections of this mass, not a curative intent, so that the bleeding will stop and the sometimes creatinine may be normalized because growth is near the left VUJ. So first,
Dr.
this
Okay,
resection
point take.
followed by the further plan the platinum plus chemo and followed by this maintenance.
Okay, Dr. Ankur. Your vote regarding the plan of management of this patient. So we have one of the senior panelists who is interested in knowing Pdl1. The other one, who is again a dear colleague, is interested in getting the resection of this tumor which is obstructing the VUJ. What will be your plan of care in this patient?
Yeah, I agree with both the things. Ideally, during the cystoscopy, maximum TURBT should be done irrespective whether the patient has a metastatic or a non-metastatic disease. Secondly, sometimes it's not possible for any other reason that you cannot, remove all the tumor. Then for a patient who has a obstruction and on the creatinine on the higher side, and we know that the response rates are not that much fast or not much rapid in urothelial cancer, I would prefer to do, PCN upfront only, so that we can have an adequate urine output. Is not our kidney function is not compromised as we start the treatment, because we can do a PCN and we can wait for a few weeks till the creatinine improves, then we can start with a cisplatin based chemotherapy.
So
Okay,
can
so
we,
Dr.
so
Jitendra,
just want to interfere. So can we put on the DJ stent temporarily?
exactly, I was coming to that, Dr. Devesh.
Because this
So
PCN
probably
so-
Dr.
Exactly.
Ankur also wanted to say that PCN, I think, would be a overkill. DJ stenting will be an internal stenting, and if it is a palliative resection, as you suggested, that's a possibility if the urologist agrees. I'm
So
coming to it.
once
Yeah, Dr. Jitendra, I'm coming to you.
why we are not interested in doing a GFR scan for the patient.
Okay. So, Dr. Jitendra, I was coming with that question to you. Now, there is a clear mention of a left VEJ obstruction. As
Yes, sir.
Dr. Devesh also pointed and Ankur also said that there may be a delay in the response. Probabilities are you may find, so what is your cutoff of the DTPA GFR in such patients? At what you are comfortable giving
So
cisplatin to?
my point is no, it's not about the cutoff. My point is we have to find out what is the cause of this raised BUN.
We
or
already
raised
have
creatinine.
we already
So,
have that in front of
No,
us.
sir. The point is, if other kidney is working fine and this kidney is only working subnutridly, maybe it is aging related renal deterioration. Because as we know, after 30 we all start aging in bone, in heart, in lung, in kidney. So
So
it's
point,
just like that.
yeah.
So my point is, you do a GFR. If both other kidney is working fine, then you think about all those things. Otherwise, you think that it is age-related changes, maybe due to the age, and then you proceed further about that.
Okay, so point taken, Dr. Jitendra, but slight difference of opinion. At 62, if the right kidney has aged, even the left kidney will also age. Since we have a mechanical obstruction.
Sir, if the kidney is aged, there is no point in doing PCN, DJ, or removal of the tumor.
No.
That's my
So
point.
please. So suppose now my cutoff for cisplatin is 60 ml per hour of GFR. Now suppose we have a right kidney which is functioning 55 ml per minute. The left kidney is functioning 5 ml per minute. However, the nuclear physician tells that there is a severe hydronephrosis on the left side. So will you offer this patient a DJ stenting, or as Divesh said, try resecting that left-sided tumor so as to improve the hydronephrosis and improvement of the function? So your point is also valid.
I will make it interesting. I will put another scenario. Suppose
No, sir. Right now, it's my job to make the things interesting. As a moderator,
if I will take this straight away, 50 versus 5, I will do a stenting. If it is 35 versus 25, I will not go for stenting.
Okay. Point well taken. So 30 and 25 means that hydronephrosis on the left is not the reason for decreased function. So I think we conclude on this first slide that we will try to find out what is the kidney function, because we know platinum based therapy, especially cisplatin, is better than other platinums, and notably carboplatin is that. And whenever there is a possibility, even the guidelines recommend that if there is some intervention which can improve the kidney function, before proceeding with the chemotherapy, start with that intervention so that you are able to give the best option to the patient as far as treatment is concerned. So coming to Dr. Tarachan, So suppose this patient had left-sided hydronephrosis, kidney function was deranged, DJ stenting was done, and now the GFR has improved to about 80 ml per minute. So what will be your choice of treatment in this patient? So
yes, sir. My choice was from beginning also the same, that I will assess the kidney and on the ultrasound, even if the GFR is good, then if there is a hydronephrosis, then I will still put a DJ stent. Then even if the GFR is good. But if
Okay.
GFR is not good, then it can be improved by the DJ stent and creatinine is borderline, or we can calculate by the formula, simple Crockford, if the DTPA GFR is not feasible, or we are not going to do.
So
And the second thing, if the patient is now the platinum eligible as per the GFR criteria, so I will go for the cisplatin gemcitabine based chemotherapy for the 4 to 6 cycles, depending upon the response. And then I will, if the patient is having the response after the after the chemo completion, then I will go for the switch maintenance.
okay. So
Evolumab.
okay, so since this patient was performance status 1, metastatic disease, platinum eligible, cisplatin eligible, so you will upfront start with the gemcitabine cisplatin 4 to 6 cycles based on the tolerance and the response, and then switch to the maintenance therapy. So that's the crux of the treatment of this patient, right? So now there are the twists and turns coming.
Yes.
So Dr. Lalit, you asked about the Pdl1 status in this patient. As we heard Dr. Tarachand, he has not waited or asked for a Pdl1. Now we need to understand from you your rationale of getting a Pdl1 status upfront in this patient. Dr.
Well,
Lalit,
the
please.
idea is we have now accumulating data that patients who are expressing PDL1 probably have a better response rate with the immuno-oncology drugs. And moreover, we have also data that the immuno-oncology drugs improve the PFS and OS far better when introduced early on into the treatment. So in case there is the PDL1 expression is good, I might consider adding on the immuno-oncology drugs upfront, or even if I'm thinking of evolumab maintenance, a better PDL1 expression would give me more confidence of achieving better responses.
So I know, rather we all know that immunotherapy are coming a big way in all the tumors, and urinary bladder cancer is no exception. But incidentally, if you see this first question, is there a role of chemotherapy plus IO in combination? No doubt, this drug is being used in the metastatic, in the second line. It is being used as a maintenance therapy, but then it was tried as a first line therapy in the upfront setting in both cisplatin eligible or ineligible. There was only a very minor improvement in the PFS, which was though clinically significant, but was so minuscule that this combination did not get this approval in the upfront first line setting. So is there anyone in the panel who would like to give this patient upfront chemotherapy and immunotherapy combination? Suppose PDL1 comes out as 10%. So out of the 5, how many of you, Dr. Lalit has already opted for the same. So remaining 4, what is your take on this? Would you be comfortable starting with the IU and a PDL1 combination? Let's start with alphabetically, Dr. Ankur.
No, I will not add.
No, Dr. Devesh.
No.
So Dr. Jitendra.
I will concur with Devesh sir and Ankur. No.
Dr. Tarachand.
Sir, no, I will go with the Javelin 100 because my concern is when I am having OS benefit, then I will opt the same.
Okay, so I think I think we are gazing in the crystal ball of future. So probably someday another trial will come which will prove the role of combination of IO and chemotherapy, classical chemotherapy, leading to the improved survival. But as on today in 2022, the evidence suggests otherwise, and upfront, we would not like to give a combination, especially as Dr. Tarachand said, when there is a OS data available for the maintenance immunotherapy drug. So we will go with that evidence-based medicine. Coming to the, these are the trials which I've already suggested that as on today, there is no additional benefit of using immunotherapy in combination in the first line. Now, coming to the question that now this patient is not a good performance status. the creatinine, the kidney function doesn't support a platinum-based therapy, not even a carboplatin. So now we move to Dr. Lalit. Now, sir, now you tell us, now this patient is not eligible for any platinum-based chemotherapy. Either you have an option of a single-agent chemotherapy, or since we had done a Pdl1 earlier, it was 10%. What will be your choice of drug in this patient?
Well, I might consider this patient for immuno-oncology drugs upfront if the Pdl1 expression is good, sir.
Okay, sir, this is your case, 10%.
Yes, sir.
You
What I
cannot say
mean to
might.
say, I'll go for the
You will go for exactly, that's what we wanted to hear. So I would request all other people to start with alphabetically. Dr. Ankur. We already have a clue that platinum is not going to be used in this patient, and all other therapies as a single agent, especially if used as a taxane or gemcitabine, they have not given a very good outcomes to her. So would you be interested in knowing Pdl1 of this patient, or irrespective of the Pdl1 status, you would give immunotherapy to this patient? And if yes, which are the drugs that you are going to give?
Yeah, I will do irrespective of the Pdl1. Pdl1 will help to make, prognostify a little bit, because high Pdl1 patients will have a higher chance of getting a response. So the drugs which I think are used as in this setting are pembrolizumab and atezolizumab for the patients who are cisplatin ineligible. I will use either of those two drugs in this setting.
Okay, so pembro and atezolizumab.
Yes.
Okay, why not nivolumab or durvalumab?
I don't think they have insufficient evidence regarding the upfront in cisplatin ineligible population.
So incidentally, durvalumab got an accelerated approval earlier as a single agent and then in combination, but when the subsequent results came in showing its inferior outcome, this indication was withdrawn. So you are very right in saying that there are, as on today, only 2 molecules approved as an upfront drug in this this type of case scenario. Okay, so coming back to the question, you have already said that unselected, you will give this patient an immunotherapy drug. So we move back to Dr. Tarachan now. Now, obviously, we all know from the experience from the other tumors that a patient who is having more Pdl1 expression, there is a predictive value of getting a response to the immunotherapy drug. Now, supposedly, although we are not going to do that in the first line setting, if we have to choose a biomarker for predicting that which is the patient who is going to get a very good response. So what do you think? Which Pdl1 testing you are going to do? You have a list of all these biomarkers which are companion diagnostics for all the drugs, out of which if we see only the pembro or atezo or nivo, which biomarker testing of Pdl1 you are going to do, whether it is SP 142, 22C3, 28A, SP263, which one is your preference and why?
Pathology by Vana, sir. So now
it's not pathology, it's something, it's googly. It's a googly.
Yeah.
So whenever you something, so I tell you, whenever I write a Pdl1 testing, there is a call from the pathology lab, sir, kaun se wala test karna hai? And then you try to scratch your head, acha, which was the trial, which was the companion diagnostic used, and then you tell them this is to be done.
Sir, if I have to go for the out of these tests, then definitely I will go with the from down to up. Avalumab, no choice, and first line. Durvalumab, as you suggested, no choice. Nivolumab, phase 2 data is there only. And the most strong data comes from the pembrolizumab in the first line in cisplatin ineligible. So I will choose the SP263 for the pembrolizumab, I think. It is fair enough to use pembrolizumab because DACO is not available at present in India. So SP263.
So I think I would also concur with you. If you see the Pdl1 pickup rate is highest with the SP263. So I would also concur here with you. Dr. Divesh, any difference of opinion of choosing the pathological test to find out the Pdl1 positivity?
Same concur with the Tarachan.
Dr. Tarachan. Dr. Jitendra?
Concur with both of you, sir.
Okay. And Dr. Lalit and Dr. Ankur?
We would concur. I would concur.
I think all of us concur. So actually, this is the
Sir,
first slide.
sir, what is the harm in doing NGS upfront if the patient is not cisplatin ineligible and has the non-cancer related life expectancy quite good? And when we are choosing PDL1 either irrespective, because we have to select at least any one drug at present, because we have to treat the patient PS is good, but the patient is not cisplatin eligible, then we can do, in my opinion, we can do the NGS and MSI and other markers also that may support the other agents or the in the other immunotherapy drugs.
So
In
very
my
right.
opinion.
Yeah, very right, Dr. Tarachan. Whenever you have a cisplatin ineligible patient, you know that the patient is not going to do well. And then you resort to something like NGS, as you already said, to find out besides finding PDL1, TMB, MSI, is there any way to give any sort of targeted treatment in the form of immunotherapy or based on the FGR expression? So that's a good idea, especially in this cisplatin eligible patient, to upfront advice for the NGS, and I think most of us are doing it in our clinical practice.
And we are having rare mutations in this cancer, so that we can find something like
right.
FGFR3 and TRA others are also there in this.
Right. So
Just want to add one more point.
Yes,
if
Dr.
there is
Dinesh.
patient are not affordable for this IO maintenance, suppose patient are giving 6 cycles cisplatin and gemcitabine and a good partial response, then what should further? Single agent gemcitabine maintenance should continue or not?
So Dr. Devesh, as on today, the maintenance data only supports a maintenance avelumab, and if the patient is not financially viable for the patient, none of the guidelines, none of the trials, they suggest any sort of maintenance treatment. It is only observation.
But few of my patients are on
right.
maintenance, they are doing good.
Right.
Because they are initially patient are given of AT in first line. PS is poor, then given 6 cycle carbogem and then jam maintenance. Even 2 or 3 patients, they are responding poor to this immunotherapy in upfront first line because they are initially cisplatin ineligible. But now we are giving carbogem and followed by the jam maintenance. They are continuing going on.
Obviously, all of us would be having such anecdotal cases where we try to do from our side some sort of intervention, and if that benefits the patient, behind every successful story, there will be 999 unsuccessful stories. Because they were unsuccessful, we don't remember them. So you are remembering the patient who are surviving because of maintenance. But many patients, not only by you, but others would have given some sort of maintenance, whether taxane or gemcitabine or some blue dose platinum, but they would not have survived to tell their story. So,
one more thing, sir, I would like to add that if we go in flashback, usually the immunotherapy gives the poor PS in comparison to the control arm, but OS was good in those cases. I think immunotherapy sometimes change the microenvironment of the tumor, and in that case, the drugs work better, I think.
Maybe there is some theory about that change of the microenvironment leading to the better responses to the classical chemotherapy drugs, and I do agree with you. We are short of time, so Dr. Tarachan that very nicely summarized what would be the course of the treatment in this patient: 4 to 6 cycles of chemotherapy, followed by, if there is a partial response or a stable disease, he will like to continue with the maintenance switch maintenance with avelumab in this patient. So any difference of opinion in all other panelists regarding this line of recommendation? Dr. Ankur?
No.
Dr. Jitendra?
This is guidelines wise, so nothing to change.
Nothing. So as per the standard guidelines, nothing is going to change. So we had Dr. Akhil dwelling very well on the maintenance by the avelumab, and there is no differentiation between the PDL1 positive or negative. And there is no, so incidentally in the trial, so when I did not have complete information about this trial, I used to think those patients who had responded well, either in the PR or the CR, which is very small percentage, but PR is a fairly large percentage, they will give a better outcome on the maintenance therapy as compared to the stable disease. But when I went into the details of this trial, and there was a talk by keynote lecture by the person who was involved in this trial, we came to realize that patients with this stable disease derived the maximum benefit of this avelumab maintenance therapy, in contrast to what our classical thinking was. have you interpreted that with this trial, or you still think that partial respondent patients are better off as compared to the stable disease when they are being put on the maintenance therapy? Any thoughts about that, Dr. Tarachan?
Sir, a responding patient, yes, always available. We go with the switch maintenance, and if we are talking about a stable disease, then also we can try. Then we can also give the avelumab. But
No.
we know,
Dr. Tarachan, question is, we are forced to think that partially respondent patients would have a better outcome to the avelumab maintenance as compared to those with a stable disease, considering the disease aggression. But when you go into the nitty-gritties of the trial, it is the other way around. Patients who had a
yes,
stable
sir.
Yes,
Yes,
have a
sir.
better
I
outcome
agree
with the maintenance as compared to those who had a partial response.
Yeah, yes, sir. The patient with a stable disease patient, I think there will be early progression, I think, on avelumab maintenance.
Okay, so now
my
this,
apologies. You are left.
yeah, I'm finishing up.
Thank you.
So now this patient had a typical about 18 months of progression-free survival on the first-line chemotherapy, which was cisplatin based, followed by avelumab maintenance. And now the patient has progressed. Now it is time to go for a second line. So one small answer by each of the panelists, Dr. Ankur. So what will be your choice of treatment in this patient? We have already used chemotherapy, 18 months, and we have used maintenance avelumab. Now, what will be your choice of treatment for this patient on progression?
Probably a second, chemotherapy like taxane would be my preferred choice, as we don't have this particular drug. We use a taxane.
Would you like to reuse the platinum in this patient because it's all 18 months from the first exposure to the platinum?
I don't know.
Anyone in the panel who would like to use
Yes, sir.
this
Exactly. I was thinking the same, that the patient is already 18-month PFS and the patient was quite platinum sensitive at that time. When we switched to the maintenance, we can use either in the form of GemCis or the DDM or MBAC, or we can, as Ankur said, we can also have another line like the paclitaxel or nab-paclitaxel. Simultaneously, I would like to send the NG for the NGS also, so that we can have another line if we get something.
Okay. So I think I agree with you, and probably all of us we agree. So in the interest of time, I will finish this panel with the parting note that in the metastatic urothelial cancers, when the overall survival used to be less than 1 year, now we are seeing overall survival which is extending beyond 1.5 to 2 years, and that's with the proper sequencing of the drugs, and that sequencing requires rational thinking based on the evidence. So we conclude this session, and I thank all of my panelists for their explicit comments and their thorough knowledge about the topic. Back to the organizers for giving me this opportunity. Thank you and good evening.
Thank you, sir.
Thank you, sir.
Thank you.
Yeah, thank you, Dr. Sandeep. So it was a nice panel discussion, and you coordinated it very well. And thanks to our esteemed panelists, Dr. Tarachan, Dr. Devesh, and Dr. Jitendra, Dr. Ankur, Dr. Lalit. You're all commented very well, and the knowledge exchange is the only way to learn further. And it was very good panel discussion. Now again, I would invite Dr. Sandeep Batra for giving a talk which is session is sponsored by the MCure, and it is a day-to-day life problem, cancer and anemia, how to go about it. So as everyone in this meeting would agree, like we are facing this problem with this all 4 deadly malignancies. Patient generally present in the very advanced age, and they have nutritional anemia, they have cancer-related anemia. So how to go about that? Which therapy will suit them? So Dr. Sandeep Batra will speak on that. So over to you, sir.
Yeah, thank you, Dr. Singh. Thank you. Geetika, can you give me the access, because I have made 1 or 2 changes in the slides. I would like to share my screen.
Sure, sure.
Okay, thank you. Okay, so here we go. And thank you once again, Dr. Asim and Dr. Tarachan, for this opportunity. And let's start with the first thing. Okay, so cancer-related anemia and evolving role of intravenous iron therapy, ferrous maltose 1000, carboxymaltose 1000 mg. We will say CRA, cancer-related anemia. So I believe most of you will get something like this from your blood bank, pending blood donation details. I tried to mask the name, somehow it was not successful. So I frequently get these type of messages, mails, phone calls from my blood bank, because most of my patients, as would be common with the cancer patients, they require blood and blood product support. And whenever there is a threshold which is breached for that particular patients, we get the hammering from the blood bank, either donate or get it donated by the patient, or you can anytime come for the donation. You are most welcome, and we are going to be happy to bleed you out. Now, 3/4 of all cancer patients have anemia at some point during their course of the treatment, whether treated or untreated. Anemia do develops in a majority. Of all the cancer patients who develop anemia, 66% are for the solid tumors and 72% for the hematological malignancies. And there are multiple reasons for developing that anemias, which are some are controllable and some are not. And 40% of all the anemias, that is hemoglobin going less than 8, or patient getting symptomatic because of the low hemoglobin levels in the form of dyspnea, weakness, fatigue, blackouts, syncopal attacks, they warrant blood transfusions. And I believe most of the daycares, if they are 20 to 40 bedded, about 2 to 3 patients will definitely be there per day for blood transfusions or blood product transfusions. In the Indian context, these figures are likely to go higher due to the prevailing malnutrition, prevailing worm infestations in the general population. So this is, if we see pancreatic, out of all these solid tumors, pancreatic, colorectal cancers, so this is the sequence. So we expect much less blood or blood product support or anemia incidence in the testicle cancers. And we find that most in the gastrointestinal cancer, especially the colorectal, esophageal, and the pancreatic cancers. So what are the etiologies of developing anemia in cancer patients? So first and foremost is anemia of the chronic disease. Cancer per se is not an inert disease. It secretes substances which, besides causing coagulation, procoagulation, anticoagulation defects, also has effects on the bone marrow and the functioning of the other organs, including the hematopoietic system, to suppress the formation of the RBCs, leading to the anemia. Now, there is additional effect of the chemotherapy and radiation therapy to all the bone marrow producing bones, directly by the radiation therapy and indirectly by the injury to the stem cells on the growing cells by the chemotherapy. Some of the targeted therapies, especially the newer oral molecular drugs targeting specifically the BRCA, they are also associated with the low hemoglobin development, anemia development, as well as thrombocytopenias, and including the drugs like CDK inhibitors for the breast cancer, where they call the maturation arrest, leading to the neutropenias, thrombocytopenias, and anemia as well. So these are the commonest factors. Besides, there are some visible factors like blood loss, bone marrow infiltration by tumor, hemolysis, vitamin B12, folic acid deficiency, uncommon one are iron deficiency, thrombotic thrombocytopenic purpures, and many others non-illustrated causes. So these are the mechanisms, of which you see there are some correctable mechanisms and some are uncorrectable mechanisms. Sorry for the tongue twist. So blood loss, if it is tumor related and you are able to control the tumor, whether by chemotherapy or radiation therapy or by surgical removal, you can reverse the cancer related anemia. But when there are the depletion of the stores in the form of nutritional deficiencies, notably iron, B12, folic acid, you need to supplement them rather than giving the blood transfusions, so as to have a low cost replenishment of the body resources, leading to the improvement in the anemia, leading to the improvement of the quality of life of the patients. So whenever there is an anemia, there are classical set guidelines which know how to work up these patients to rule out anemia which is related to chronic disease versus anemias of deficiencies, because there is a difference between the correctable and non-correctable things. Correctable, if we correct, we decrease the cost of the treatment. So this is the pathophysiology of cancer-related anemia. We have already dwelled upon that. Anything that leads to decreased erythropoiesis leads to CRA. Now, so mere presence of iron in the diet or in the blood is not a sentinel for a good hemoglobin. even in the presence of a normal iron, or for that matter, other vitamins, those essential for the hematopoiesis, the body may not be able to use that properly, leading to development of the deficiencies. So whenever there is an absolute iron deficiency because of the insufficient iron available, which may be further due to inadequate iron intake because of the intolerance, because you get so much of nausea, vomiting with the chemotherapy drugs, plus the GI side effects of the oral iron therapies, you are definitely bound to get absolute iron deficiency. And another is the chronic blood loss in the form of some bleeding ulcers in the upper GI or in the lower colon, so leading to iron deficiencies, anemia. Another is the functional iron deficiencies, when you have adequate iron stores that you have checked with the blood test iron profiles, but despite having the adequate iron stores, the supply to the erythron is limited, leading to the decrease in the maturation of erythroblast, decrease to the response of the erythroblast stimulating agents, leading to the decrease in the hemoglobin. And you identify them by, if ferritin is less than 30 or more than 30 is absolute iron deficiency versus functional iron deficiency. Same way, transferrin saturation less than 20% and more than 20% is the differentiator between the absolute and the functional iron deficiency. And if you see in the peripheral smear, hypochromic red cell percentage, if it is very high, reticulocyte hemoglobin content, if it is low, and erythrocyte protoporphyrin. So these are the pathological parameters that we need to see and discuss with the pathologist to elucidate whether it is a absolute iron deficiency or a functional iron deficiency. What are the outcomes of cancer-related anemia? Anemia, whether it is cancer-related or not cancer-related, is definitely bound to cause compromised quality of life, because it decreases the delivery of the oxygen to the whole of the body, including the brain. So will not have the proper functioning without the oxygen. This will further lead to a fatigue. The performance status further decreases because of the presence of anemia and because of the other cancer-related symptoms. Because of the decreased blood supply to the brain, the oxygen supply, you have impaired cognitive function, which is also compounded by the something called chemotherapy brain, the cumulative effect of all the things happening. Anemia also leads to aggravation of respiratory and cardiovascular, which are so common in the old age group, especially more than 60-70 years, when you have other COPDs, hypertension, cardiac failures, etc., which is further compounded by the anemia, leading to the compromised quality of life. Anemia further leads to poor tolerance to chemotherapy, compromised dose intensity, and this all may, if uncorrected, lead to a premature death because of the anemia-related complications. As a dictum, most of us are tuned to keep a hemoglobin level of more than 8, more so for the radiation when we try to maintain a hemoglobin level of more than 10, because it improves the tolerance to the chemotherapy as well as the improvements of the performance status, leading to the maintenance of the drug intensity. So whenever you come across a cancer-related anemia, what are the goals of the treatment? Having documented that a patient has a cancer-related anemia, the goals of treatment are obviously to improve the hemoglobin levels, which will indirectly lead to improvement of the quality of life. And this will also lead to decreased need for the recurrent admissions for the blood transfusions, leading to the decreased cost of care, which all will cumulatively lead to better treatment outcome for the cancer patients. Now, as a physician doing our MD medicine, we already know how to evaluate anemia to find out what is the cause. And the same thing has come in the guidelines. Whenever you are suspecting a chemotherapy-induced anemia, try to ascertain the cause, whether it is a correctable or a non-correctable thing. So any patient who has a hemoglobin of less than 11, so these are Western guidelines, I would put a figure of less than 10, or which has dropped more than 2 grams for the baseline. So besides ordering a CBC with the peripheral smear, the things that need to be checked are reticulocyte count to find out whether there is a hemolysis or not. Ask for the specific questions because patient may not be well aware about telling their symptoms. Assess about the hemolysis with the Coombs direct and indirect and other tests to find out about the hemolysis. Assess about the nutritional history, whether the patient is taking sufficient minerals or vitamins in their diet. Any renal dysfunction which is evident with the reduced kidney function or increased serum creatinine. any radiation history in the past, especially to the pelvic area in the adults. And besides any history of hyperthyroidism, hypogonadism, or adrenal dysfunction in the past, or any chronic inflammatory disease like autoimmune diseases in the past. If you get these type of things, you have to treat them. But if you do not find any of the causes as mentioned in this, then you further work up these patients. Now, if patient does not have any significant comorbidities and is asymptomatic with the hemoglobin of somewhere around, you might well observe the patient because you did not find anything sinister. But a patient who has a progressively decreasing hemoglobin with the comorbidities of age-related comorbidities of cardiac disease, chronic pulmonary disease, or CVA, in which a hyperdynamic circulation may create a problem, which may be cancer unrelated, but may cause significant blow to the cancer treatment, leading to the poor outcome. Then you consider giving blood transfusion because you have not found any reversible cause. And if the patient has other symptoms besides these, like tachypnea, chest pain, lightheadedness, income, the symptoms that are associated with this severe anemia, blood transfusion is the standard guideline, provided you don't find any correctable measures in all your previous investigations. Now, what if you find an iron deficiency and you find it that this iron deficiency is a real absolute iron deficiency, not a relative iron deficiency, as we saw in the previous 3 slides back. So absolute iron deficiency will be defined when ferritin is less than 30 and transferrin saturation is less than 20%. And in these patients, you consider IV or oral iron supplementation. And most of us know that the tolerance to the oral iron supplementation is not that very good. Most of the patients come back with the complaints of pain, nausea, vomiting, altered bowel habits, and we tend to shift them from the oral to the intravenous one, which is a single shot, which may be repeated on a monthly basis till the time your iron stores are replenished, so that there is an improvement in the cancer-related anemia. Now, so this flowchart, which is taken from the NCCN, dwells upon when to consider the IVRN therapy and when not to consider IVRN therapy, and that is categorically when you have a high ferritin levels, you have a high transferrin saturation. That means body is no more receptive to further iron therapy. These patients will not benefit from any iron supplementation, and you have to treat either the cancer or you have to transfer them with the PRBCs so as to improve their hemoglobin. All the guidelines, they suggest to maintain a hemoglobin of 8 to 10 gram per deciliter, and if you have iron deficiency, they suggest either oral or intravenous. And intravenous, if it is given either 500 to 1000 milligram doses in a single infusion. And you can start seeing the effects within 2 to 3 weeks time by the accelerated erythropoiesis, leading to the improvement in the hemoglobin levels. And if erythropoietin levels are also low, then you can give erythropoietin stimulating agents, which will add 1+1, leading to the improved hemoglobin formation in these patients. Now, when do you need blood transfusions? When do you need erythropoietin or stimulating agents? And when do you need intravenous iron? When hemoglobin is less than 8, there is a need for the immediate increase in the hemoglobin. You want that in a very short time. Otherwise, there is a severe risk of mortality and there is a blow to the treatment intensity. These patients will definitely require packed RBCs or blood transfusions. Patients who have a hemoglobin more than 8 but less than 10, whose hemoglobin, even if there is a slow increase, is not going to worsen the treatment outcome or increase the problems, will require erythropoietin stimulating agents, provided their erythropoietin levels are low. However, there is a risk of thromboembolic complications, and there has been always a debate about using erythropoietin stimulating agents in the metastatic patients, with the risk of increasing the stem cells of the cancers, leading to the poorer outcomes. And last, whenever there is an absolute iron deficiency, that will be an indication for the intravenous iron. No doubt, hemoglobin should be more than 8, preferably between 8 to 10 and not less than 8. And the advantages are there is a long-term effect, ongoing effect, and a low-cost alternative to blood transfusions, and it is well tolerated. Lesser chances of these side effects like reactions as is there with the blood transfusion. So pros we already have seen for the red blood cells transfusions, and the side effects we know of the cones of the blood transfusion and the form of increased course, chances of anaphylaxis, transfusion-associated lung injury, GVHTs, increased infection rate. If there is no good screening matching done, chances of hepatitis, which may be delayed manifestation. We have all seen in our practice patients who develop hepatitis or HIV positive despite having received a well-screened blood transfusion in the past. With the erythropoietin, the cons are thromboembolic complications, hypertensions, and always there is a risk of tumor progression with the hypothetical risk of stimulation of the stem cells of the cancers. Coming to the iron therapy indications, when the oral iron
My
is
apologies, sir. Request
finishing
you to
up in
kindly
1 minute.
conclude.
I have
Yeah.
2 minutes to go. So
Yes, sir.
oral iron is the preferable thing, but most of the patients do not tolerate. So we have to go with the intravenous iron and supplemented with the erythropoietin stimulating agents. This works better. So pros are low cost, gives the reserves to the patient, resulting in the rapid increase in the hemoglobin as compared to the oral iron supplementation with the positive impact on quality of life. The only thing is it requires hospitalization, and some of the brands may be associated with infusion reactions. And that's why this company has come up with the ferric carboxy maltose. And most of the brands that we have used, I think only one reaction seen with the one of the other brands. And after we have shifted to this molecule, I'm yet to see a transfusion related reactions. So this is the chart which shows patient. This is a study. There is a study from the India as well, which shows, yes. So this is a Rishikesh paper with the anemias. There was a 4.2 gram per deciliter mean increase in the hemoglobin after 3 weeks. That's an impressive increase. Since it is an Indian data, I am going to believe this data. And with this, I will summarize that iron deficiency is a frequent complication of cancer. It's associated with the cost, functional and emotional cost and impairment of the cancer patients. Cause of iron deficiency needs to be clarified. IV iron increases the hemoglobin, improves the symptoms and quality of life, and when combined with the erythropoietin stimulating agents, the results are better, and newer preparations and the law are well tolerated. So this is from the company, ease of administration and effective, induces rapid response, no test dose needed, no GI tolerance, and it is cost effective. With this, I will thank my talk well in time, 7:50, and thank you, I thank the organizers again for their invite, and Tarun and team for providing the logistics. Thank you, Dr. Asim and Dr. Taraj.
Yeah, thank you, sir. Thank you, Dr. Sandeep, sir. You have taken a long session of moderation and this talk, and it was very nice and enlightening us. And it was a very day-to-day life problem we are facing, and you have given the enough light over there. So thank you very much. And